Hello, again, I'm Will Harris. I'm one of the vascular surgeons at Vascular Institute of Chattanooga. Thanks to all the previous speakers. I think we've got an exciting session up next. Over half of our critical limb ischemia patients have wounds, and so wound care is an integral part to our business and an integral strategy towards helping these patients save their limbs. We work in concert with wound care centers all across the region, as well as podiatrists and wound care specialists, and we even have some wound care specialists in our practice who are certified. With that, we'll get going. Our first speaker is Dr. Barry Shulman. He is a podiatrist who hails from the upper regions of New York. He went to SUNY Buffalo for undergraduate and completed medical school at the New York College of Podiatric Medicine and completed a surgical residency at Wyckoff Medical Center. He was past president of the Tennessee Podiatric Medical Association and has been in all elected positions on their board since 2006. His lecture is going to be on non-healing wounds and what's the deal. We'll follow up with that with Jenny Wilson, who's been a nurse practitioner with Chris, my partner, for years and has been with Vascular Institute of Chattanooga since the start. She's an accredited family nurse practitioner and serves as one of our wound care specialists. She is a certified wound specialist by the American Board of Wound Management and is a member of Sigma Theta Tau International Honor Society of Nursing and the American Association of Nurse Practitioners. Jenny will be speaking about ischemic assessment and treatment for successful wound closure, which is a problem that we face routinely. We'll follow that up with a talk by Ashley Cates, who's one of our newer onboarding nurse practitioners. Ashley is also an accredited family nurse practitioner and also a certified wound care nurse by the Wound Ostomy and Continence Board. She joined Vic and has established wound clinics both in Chattanooga as well as in our Cleveland office, and sees vascular patients in addition to her wound care patients. Ashley is a member of the American Academy of Nurse Practitioners and the Chattanooga Area Nurses in Advanced Practice and Sigma Theta Tau Nursing Honor Society. Ashley will be talking about chronic wound insufficiency and a life-altering wound issue. A lot of these wounds have very chronic wounds that last literally for years until they actually see and seek out the appropriate care. Finally, Ashley Wright, who's a family nurse practitioner, has been in the Chattanooga community providing care since 2012. She received her bachelor's in nursing from Samford University in Birmingham and started practicing it as a bedside nurse in a cardiac step-down unit as well as a cardiac intensive care unit, where she gained invaluable experience in critical care. She discovered a passion for wound care from there and healing the geriatric population, and she got her master's and became a board certified nurse practitioner from the University of Tennessee, Chattanooga. She has joined the Integrametrics team to provide consultations for acute and chronic wounds and provide education for the community. She'll be talking about advanced therapies in wound care. So looking forward to all these talks, and with that, we'll get started.
My name is Dr. Barry Shulman. My topic today is non-healing wounds. What's the deal? There are many ways to heal a non-healing wound or a chronic wound. We're not going to focus today on those wound care products, those advancements that have been made, as that is a very big topic. Require more time than we have here. I'd like to talk about more of the basics of chronic wound healing, and that is what are those underlying factors that not necessarily focused on that could create a non-healing wound. So some of the intrinsic factors that can affect wound healing, such as patient's age, nutrition level, depth of the wound, comorbidities such as diabetes, peripheral arterial disease, the inability to control any of these factors can cause a non-healing wound. Other factors outside the body, friction, personal hygiene, the use of tobacco products also can cause a wound not to heal or heal very slowly. The inability to control any of these factors can also cause chronic non-healing wound. So nutrition obviously plays a big part in wound healing. Many of these patients that you'll see have disease states and have poor nutrition, and it's always wise to make sure that this particular topic is covered. I usually, if I suspect significant poor nutrition with the patient, I will refer them to a dietitian or a nutritionist. The second topic of why a wound will not heal is where the wound is located. Some wounds lend themselves to heal faster than others according to where they are. Those wounds that are down to capsule or tendon tend to be more difficult to heal, as these are avascular structures and do not have a good blood supply to begin with. Put on top of that a bacterial infection and or pressure, and these are very difficult to heal. Although, another area that's difficult to heal would be any bony prominences, such as plantar aspect of the foot, mostly the heel or posterior heel, the fifth metatarsal base, or the navicular tuberosity, or below the metatarsal head, especially if one is more prominent than the other. So there are medications. You have to look at the person's medication list to make sure they're not taking some sort of medication that reduces their ability to fight infection and heal the wound, such as chemotherapy, corticosteroids, cytotoxic medications, NSAIDs. Make sure these patients don't take these medications, or at least have these medications looked at by their primary care physician or other specialists, and see if there can be some other way that the person's condition can be treated, as this will work against you in treating a chronic wound. If they can't, then you just realize that you might be in for the long haul. Obviously, there are many disease states that are associated with the risk of foot ulcerations: diabetes, peripheral artery disease, peripheral neuropathy, coronary artery disease, musculoskeletal deformities that cause antalgic gait or prominences or contractures of the foot. So the non-healing wound, the golden rule for, at least for diabetic foot ulcerations, is that if 50% of the area of the wound does not heal within 4 weeks, then the chances of it healing at 12 weeks is poor. And basically, this is true. It rings true. So you have to ask yourself, why doesn't a wound heal? Is it you? Is it the patient? Is it both? So the big question, the approach that I always take is there are patients with diabetes that don't have wounds, patients with neuropathy that don't have wounds, patients with peripheral artery disease that don't have wounds, abnormal foot types. Why does this particular patient have a wound? And you have to just step back and look at the person as a whole and figure out why this is. So one of the first things I like to look at is the patient himself. You know, as the patient walks in the room, does this look like someone who is normal? Do they have a normal gait? Are they wearing normal clothes? Are they wearing ill-fitting shoes? Are they look like they can take care of themselves? Are they with someone? Does that someone look like they can take care of this person? Or are they just as bad off as the person they're taking care of? So you have to look into these things, because you're going to need these people to treat their wounds. You're not with them at home, and they need to be treated at home. So the person and the person with them, are they going to be able to help you in treating this chronic wound? The other thing is, you know, when you are treating these patients, you know, is the patient doing the right thing? Are they putting on the wound care product that you prescribed? Are they putting on the bandage the right way? You know, is the Aquacel AG or the Santal or the wound care product that you prescribe, is it on the patient, or is it substituted with something else? Did the patient even go out and get it? Did they get the prescription? You know, did they get it delivered to the house? These are all things that you need to know when treating chronic wounds. One of the first things we talk about you have to go back after a wound doesn't heal. A lot of times I go back and look at the history of the wound, and maybe there's something I missed. You know, how did it occur? You know, did I have my facts straight? Did did the person have its facts straight? Is there something I missed, right? This is something that doesn't cost anything. It just goes back, you just go back and you look through the history of this and see if there's anything you missed. One of the important thing is, if you're going to bring a spouse or some significant other that's taking care of a lot of these patients, especially elderly patients or disabled patients, is that patient that's helping them an enabler? Are they, again, lying to you? Are they enabling this patient and they say when he's not weight bearing that he really is? So you have to sometimes take what the spouse or the person that's helping to treat this patient with a little grain of salt, especially if there's a non-healing wound. Is this patient helping you out or not? So the other thing you have to look about is you can put all the most expensive wound care products on there, expensive dressings, other things like that. If the patient lives alone and they're disabled, do they have the flexibility? Do they have the ability? Do they have the eyesight? Do they have the dexterity to put on the wound? Do they have to put on the wound care products? Do they put on the bandage? Can they change the bandage? Especially, imagine a bandage that has to be twice a day. It has a significant amount of exudate. Can this person do it, and can they do it correctly? Otherwise, you might want to change your approach. You might want to do a different type of bandage to put on there. You might be prescribing a bandage or a wound care product that the patient simply can't put on. So you have to look at this. It's very important when treating a chronic wound. Can the patient follow directions and have the flexibility or dexterity or the eyesight to put on what you want them to put on? So one of the things, obviously, after that's all taken care of, you have to look at the physical exam. All of us do a great physical exam. We examine all those things, to determine if a wound will heal. But we have to look beyond that and find out, when you're healing a non-healing wound, is there more to the physical exam than really exists? So one of the biggest ones of this is the vascular component. I find this is the most difficult to diagnose. Even with there being capillary filling times instant, and there's palpable pulses, and there's warmth, and there's they're not a claudicant, or there's not rest pain, these sort of things. There are some physical exams in the vascular component that are more, I think, predictive than others. But again, it's not necessarily true. And when you're chronic wound healing, you can't take any of that for granted, right? I'm always suspicious of PAD in a wound that has palpable pulses, and I'm not afraid to have them sent out for further testing. Secondly, I'm also not afraid if they've had a previous procedure done, a stent or angioplasty, and it might have been 2 weeks ago, right? If I think that they're not getting sufficient blood flow in there, that something's changed, that there's restenosis, I have no problem referring them back for vascular follow-up, okay? Obviously, infection, we know, is going to delay wound healing. Infection's very difficult to tell whether it's biofilm, slough, or necrosis. With infection, most of the time these wounds have multi-drug resistant bacteria. You're not going to find one particular antibiotic that heals it all, but it's just part of your armamentarium that I consistently reculture wounds, especially if I think they've built up a resistance to them, and always get an infectious disease consult as well, as they are far more versed than I am in dealing that, and especially when there's multiple bacteria in the wound, they can help sort out which is the one that's going to be the infected organism. And then obviously sometimes you just have to go to surgery. All right. Sometimes they do not respond to any of the treatment, and you have to go and do surgery on them. Obviously, pressure, very difficult to do. When someone is neuropathic, they have no idea. If your peripheral nervous system tells you when there's pressure and they have lost their sensitivity, then it's impossible. So you really have to rely on your eyes and realize whether or not this person has significant offloading going. Never rely on the patient to know that they're offloading. Never take them for granted that they know. And then the last thing is, you can use all the foams and you can use all the gauze you want, and the padding, but there's still shear forces related to that, especially on weight bearing, 5,000 steps a day, that you have to make sure that the wound is sufficiently offloaded. Okay, you can dispense DME, you can dispense walking boots, but remember, these all require patient compliance, and you can't necessarily require and believe that the patient is wearing these when they're at home. Obviously, total contact cast is the gold standard, but again, not always what we can do, certainly not in the office. Most of the time, insurances don't pay for total contact cast to be placed on the foot. There are times when they're contraindicated, especially in peripheral arterial disease, significant deformity, or significant infection. But remember, not able to sufficiently manage pressure, offloading is responsible for a significant amount of surgery that occurs in people where if I can't significantly offload it, then a lot of times I'll do surgery to remove a particular bone or a series of bones to do that. So in summary, your approach to chronic wounds must always go under constant process of reevaluation because has things changed over the course of treating this wound. Never approach wound and wound care without considering the patient as a whole, whether or not they can follow directions or treat the wound. Are there underlying disease states such as nutritional issues that need to be addressed? Always consult those specialists to help optimize the patient. Inadequate offloading, failure to diagnose, treating underlying peripheral disease, and inadequate infection control are the three greatest mistakes that people make in treating chronic wounds. It's not the antibiotic, it's not the advanced wound care product, it's always those underlying three things that something is not right that leads us to lead this to be a chronic wound. Remember, even the best wound care strategy and medical management of patient, many chronic wounds may not heal and do require surgery. And remember, don't be afraid to refer your patient to another clinic or wound care center. Be honest with yourself and the patient that if the wound's not progressing, you need to change your approach. I usually do 4-week period before I change my approach to a wound, whether it's retesting, reevaluation, or with different wound care product. And remember, with non-chronic healing wounds, there's rarely a magic bullet. Don't rely solely on the most advanced antibiotics or wound care products to solve. Thank you very much for your time.
My name is Jenny Wilson. I am a nurse practitioner at the Vascular Institute of Chattanooga. I'm going to be discussing ischemia assessment and treatment for successful wound closure. Why is ischemia assessment important? This patient is a prime example. She was an 82-year-old patient who had been treated at an outside facility for 4 months for rubor and edema to her foot. She was being treated for gout. She did have a history of hypertension, hyperlipidemia, and type 2 diabetes and had not been assessed for arterial disease. By the time that the patient made it to our practice, unfortunately it was too late and she was not a candidate for limb salvage. The tools that we have available to assess for ischemia include the ankle brachial index, which is a comparison of the blood pressure at the ankle and at the brachial artery in the arm. Also is the toe pressure, which is the blood pressure in the great toe. In a non-diabetic patient, a toe pressure greater than 40 indicates wound healing. And in a diabetic patient, a toe pressure greater than 50 is predictive of wound healing. We also have the plantar acceleration time. The plantar acceleration time is an ultrasound technique that involves directly imaging the plantar arteries in the foot. This helps us to connect the dot between the ankle and the foot, where we previously didn't know what was going on. The PAT can be helpful in patients who are diabetic, who have a falsely elevated ABI secondary to calcified vessel walls, and also to patients who are status post a toe amputation or a TMA, where you can't get a toe pressure. The PAT is also helpful in patients with non-healing ischemic ulcers because it helps to pinpoint flow to a particular area of the foot. The acceleration time is the measurement of the start of systole to the peak of systole. A faster acceleration time equals less obstruction. In contrast, an artery with obstruction has a delayed acceleration time. The concept of PAT was initially presented to us by Jill Somerset, and she and her team did a study of 499 limbs over a 1-year time period, and they compared PAT with ABI to give us this chart as a guide to go by. We've been using the PAT for about 2 years now. We still use it as an adjunct in understanding perfusion of the foot and not as a standalone diagnostic tool. I'm going to discuss a few patients. Case study number 1 is a 60-year-old patient who presented to our office with complaints of rest pain in his left leg and a wound on his left anterior calf that had been present for 5 months. The patient had a history of CABG and a right femtib bypass. He is a type 2 diabetic, has a history of smoking 2 packs per day for greater than 40 years, and is not interested in smoking cessation. This is what his wound looked like when he first presented to the office. He had a lower extremity arterial duplex that suggests a 0 toe pressure and absent PAT in the left arcuate, medial plantar, and deep plantar arteries. There was greater than 75% stenosis in the left SFA and popliteal arteries, and occlusion of the posterior tibial artery. He underwent atherectomy, PTA stent of the left proximal, mid, and distal superficial femoral arteries, and his post-op ultrasound suggests an improvement. The tech did note that there was continued heavy plaquing in the left superficial femoral artery and popliteal arteries, but our toe pressure went from 0 to 53 with an improvement in the plantar acceleration time. At this point, we progressed with wound care using both Santel and sharp debridement, and the patient's wounds improved. The wounds resolved in May of 2020. He did not come back for follow-up until July when I got this picture. Second patient is a 69-year-old patient referred for non-healing wounds on his left calf and foot that have failed to respond to wound care. The calf wounds have been present for 6 weeks, and the foot wound has been present for 5 months. The patient has an extensive history of bilateral lower extremity arterial intervention dating back to 2009, including a left femoral tibial bypass. He is a non-diabetic. He does smoke 2 cigars per day. This is a picture of the patient's wounds when he first presented to our office. He had a lower extremity arterial duplex that suggested occlusion of the left popliteal, posterior tibial, and anterior tibial arteries. His left femoral tibial bypass is chronically occluded. His toe pressure is 34, and the PAT suggests occlusion of the medial plantar and deep plantar arteries. Patient had PTA of the left SFA, PTA, atherectomy, and stent of the left popliteal and anterior tibial arteries. His post-op lower extremity arterial duplex suggests an improvement in the toe pressure. It's up to 66. His medial and deep plantar arteries are now open, and his wounds begin to progress. There is bone exposed in the calf wounds, and the wounds continue to progress. The smaller calf wound did kind of stall at this pinpoint area and failed to make any continued progress. And then the wounds started to backtrack, and we had new wounds opening on the calf. The patient had a 3-phase bone scan, which suggested focal osteomyelitis in the left tibia. The patient underwent surgical debridement of the infected bone. During that procedure, a stent that was previously placed in the posterior tibial artery, which is now occluded, was visible secondary to erosion from the infection. The stent was resected, and a negative pressure dressing was applied after the debridement. This is the patient's first post-op visit in the office. You can see that the wound progressed with the negative pressure therapy. And then in September, the calf wound was closed. We still had the foot wound that we were working on, and it was making progress, and it continued to progress and closed in October. The third patient that I'm going to talk about is one that I discussed last year, and I wanted to revisit her and kind of catch you up on what had happened since last year's presentation. This patient is a 61-year-old who has mixed arterial and venous disease, type 2 diabetes, and has a history of smoking 2 cigarettes per day for 10 years. She has a history of multiple lower extremity arterial interventions in the right lower extremity. Most recently, at this point last year, had been in July, and also had a history of a right greater saphenous vein ablation in August. She was being treated for a venous wound on her right medial ankle, and the wound was improving. At this point, she was changing her dressing at home and wearing a Tubigrip for compression. On October 11th, she called the office and stated that her wound was increasing in size. She had increased pain, swelling, and drainage from the wound, and was concerned that it was infected. She came into the office, we assessed the wound. You can see that she has granulation tissue there. We did culture the wound, and it came back negative for any evidence of infection. She also had a lower extremity arterial duplex that suggested no flow at the ankle and a 0 toe pressure. And you can see that her PATs are also not good. The patient had atherectomy PTA of the right superficial femoral and popliteal arteries. And when I presented last year, I had her post-op PATs, which showed a significant improvement in flow in that leg, and had this picture where the wound had granulation and was decreasing in size. And you can see that the next month that it did close. She called again in January of 2020 and stated that similar situation, that the wound had opened, it was draining, was very painful. And so we brought her back into the office, repeated that lower extremity arterial duplex. And once again, we have occlusion of the right superficial femoral artery, posterior tibial and anterior tibial arteries with a 0 toe pressure and PATs that are suggestive of ischemia. The patient had a right SFA and popliteal atherectomy and drug-coated balloon angioplasty. And her post-op lower extremity arterial duplex suggests improvement. Toe pressure is up to 89 with an improvement in the PATs as well. And you can see the progression of the wound, and by the end of February, it had once again closed. I like to use this patient as an example because she has mixed arterial and venous disease. When you're assessing her wound, you can see that she has granulation tissue, the location of the wound, everything about it looks more like a venous wound than arterial. But it's important to remember in these patients that have arterial disease that could be affecting the venous wound and its healing. So in closure, ischemia can present in an obvious manner, such as gangrene, like the first patient that I presented, but may also present as a slow or non-healing wound. It's important to assess all wounds for arterial insufficiency, and you need to consider the patient's risk factors for peripheral artery disease. If a limb has been revascularized, but the wound fails to improve, look again. We can open arteries up, but sometimes they close again, and the patient may need more work done. We do have new diagnostic tools that can improve wound healing, revascularization, and prevent amputations that we are incorporating into our practice each day. Thank you.
Hi, and welcome to the third annual Faces of PAD conference. My name is Ashley Cates. I am a nurse practitioner at the Vascular Institute of Chattanooga. I'm a certified wound specialist through the American Board of Wound Management. I'm also certified as a wound care nurse through the Wound Ostomy and Continence Certification Board. I am going to be presenting to you all today about chronic venous insufficiency. I have no conflicts of interest to disclose today. The objectives of my presentation are for you to be able to identify the pathophysiology of chronic venous insufficiency, for you to be able to know the signs and symptoms of CVI, learn how to grade the clinical signs and symptoms, as well as to recognize the different treatment options for both venous insufficiency, as well as the late-stage signs of CVI with venous leg ulcers. Venous disease is very common, and according to the Society for Vascular Surgery, chronic venous insufficiency may affect around 40% of the U.S. population. It's more common in women, especially if they've had multiple pregnancies. It's also common in middle-aged or older individuals or people who are overweight or obese. Our veins, when they function normally, return back blood from the peripheral vascular system back to the heart through the use of muscle contraction, also known as the calf muscle pump. One-way valves within the veins help to carry the blood one way. In chronic venous insufficiency, the valves do not work properly, which causes a backflow of the blood and increases the venous pressure. The blood pools in the veins and puts pressure on the vein walls, causing the signs and symptoms of CVR. Valve damage can occur due to hereditary reasons or due to history of DVT. The signs and symptoms of chronic venous insufficiency include pain, which the patient may describe as heaviness, throbbing, aching, or pressure. They can also have development of varicose veins or spider veins, reticular veins. Lower extremity edema can occur. It's often described as worse at the end of the day. Leg dependency worsens edema. Patients may describe an increase in pressure in their legs when they are walking. This is also known as venous claudication. Edema can be bilateral or unilateral. As CVI advances, skin changes can be observed, hyperpigmentation with hemosiderin staining, lipodermatosclerosis or atrophy blanche. Patients may report itching. This is often due to hyperpigmentation or other skin changes. Venous ulcerations can occur as the chronic venous insufficiency advances with any current wounds which are active or if they have former wounds which have resolved. The C classification system is used to grade the clinical manifestations of chronic venous insufficiency. It goes from C0 to C6. C0 is no visible or palpable signs of venous disease. C1 are those little spider veins or reticular veins. C2, varicose veins. C3, edema. C4 are all skin changes, hyperpigmentation, eczema, lipodermatosclerosis, and others. C5 is a healed venous ulcer. C6 is an active venous ulcer. So chronic venous ulceration, ulcers may have a varying onset or timeline that the patient reports. Sometimes patients don't even know how they first developed the wound. They can develop just on their own. Those are usually observed in the medial calf area or ankle. Sometimes patients report that the wound is associated with the trauma and it just never failed. It never healed as it should have due to the chronic venous insufficiency. Other triggers can include cellulitis, episodes of contact dermatitis, rapidly developing edema, burns, excoriations, or scratching at dry skin, or even from insect bites. It's also important to know if this is the patient's first time with a non-healing wound or if they've had multiple occasions of this happening. Diagnosis of chronic venous insufficiency is made with non-invasive ultrasound testing. During the ultrasound test, the deep and superficial vein system is checked for valve reflux to check if the valves are not working correctly, if they're incompetent. In certain situations, IVC and iliac vein ultrasound can be performed, which checks for vein compression. So the treatment of venous leg ulcers, a big one is compression. Moderate to high grade compression is recommended for patients with venous leg ulcers. Of course, this is phases of PAD, and we're talking a lot about peripheral artery disease today. So I just want to add that we need to be cautious when applying moderate to high grade compression on our patients if there is any suspect mixed arterial and venous disease. Knowing the patient's ankle brachial index is important if we do think the patient might be dealing with some arterial insufficiency as well. Other conservative treatment of venous leg ulcers or just CVI in general is leg elevation and exercise. Exercise not only helps with weight control or weight management, as I have listed here below, it also works the calf muscle pump, which assists in edema reduction. Of course, the wound needs to be treated. Serial debridement is recommended to help with wound healing. There are a variety of topical agents that are available depending on the characteristics of the wound. And there are many advanced therapies for wound healing, including skin substitutes, growth factors, negative pressure wound therapy, and others. Surgical treatment of the chronic venous insufficiency can include superficial ablation with laser or foam therapy, coil embolization, and also venoplasty or stenting of the iliac system. So I wanted to run through a case study with everyone. This is one of my patients. He's a middle-aged male patient referred to VIC, or for venous insufficiency and chronic wounds to his left lower extremity. He does have a past history of bilateral greater saphenous vein ablation several years ago by MD at an outside facility. These wounds on his medial calf, also his ankle, which is not shown, are recurrent and have been present for around 2 to 3 years. He has not seen anyone for wound care during that time. He's just been taking care of it himself at home. But he had reported that he just really deteriorated. He was compliant with consistent daily compression using moderate to high pressure compression for many years. He works in a career where he stands for long periods of time, most days of the week. He had many of the classic changes in his skin from chronic venous insufficiency, as well as, of course, the large ulceration with a large amount of devitalized tissue. Here is his ultrasound that he had at his first visit at Vascular Institute. You see that the greater saphenous vein is absent on ultrasound testing, which is consistent with the previous greater saphenous vein ablation. He did show small saphenous vein reflux and a incompetent perforating vein with reflux noted at the mid-calf, which is around the area where he has the wound, or the largest wound. I brought him back because of his symptoms and got an IVC and iliac vein ultrasound as well. It showed mild narrowing of his left common and external iliac vein, as well as thrombus. The patient was referred for venogram. He was also started on rivaroxaban for the thrombus, as he did not know he had never reported any history of DVT. The wound was treated topically, and he returned weekly for our serial wound debridements at the wound clinic. He also had compression applied weekly. This picture to the right is a picture of his wound just prior to his venogram procedure, which he underwent at Vascular Institute. When he had the procedure, he was found to have a significant narrowing at 70%, and his left common and external iliac vein was treated with stenting. Patient was seen back in clinic on post-op day number 4 after the venogram. Could already tell a difference in his leg swelling, not much in the changes in his hyperpigmentation around the wound. It's still really dark, but the measurements of the wound were decreasing, even just on post-op day number 4. The patient continued with wound care at Vascular Institute with treatment of the superficial vein system. Was recommended after recovery from the venogram. This was recommended to assist in complete wound closure. So he underwent endovascular laser treatment of the small saphenous vein, as well as coil embolization at the incompetent perforator. This picture is just pre-procedure of the superficial vein treatment. This is on post-op day number 3. The ultrasound that he had that day was showed successful EVLT of the small saphenous vein, and it also showed no remaining reflux in the perforating vein, MACAP. This is the current progress as of week 10/26, 2020. As you can see, it's getting very close to closure. I expect he's probably going to be closed within the next week or two. Here's a side-by-side from his initial office visit to his current progress. It's pretty remarkable being able to see the before and after. Unfortunately, I don't have a completely resolved wound to show you, but I'm excited to be able to show the progress that this patient has made. I want to thank you for tuning in to the Faces of PAD conference. Thank you for taking your time out of your day to listen to my presentation on chronic venous insufficiency. I've listed my contact information here below so that if you have any questions, feel free to contact me through that route. Thank you very much.
Hi, my name is Ashley Wright, and I'm a nurse practitioner and a wound care specialist. I work for Integumetrics, and I cover the inpatient and outpatient wound care at Park Ridge, Maine. I am thrilled to be with you all today, and I'm thankful for this opportunity to discuss the advanced wound care that we can do in the outpatient setting, as that is my jam. Thanks for having me today. There's so much content under this topic, and it is taking everything in me, side note, multiple videos to get this under 20 minutes, much less around 10, because there's just so much information that I feel that it is doing a bit of injustice to the wound care world to focus on one topic. But I will comply, and I am thrilled to talk about this topic. So I am going to do my best to breeze through, and we will hopefully I don't run 1,000,000 miles an hour. So let's start with wound healing. I think first I took out a bunch of slides about wounds in general and wound assessment. As I read the itinerary, I know other people probably have already talked on that, but I think there are some key aspects that we have to know how to accurately assess a wound. I'm not going to talk about it today, but knowing that we cannot heal a wound if we don't know what we're looking at. If we don't know the structures, the ones that are non-viable and the ones that are viable, the ones that need to be removed and the ones that need to be protected. If we don't know what phase of healing this patient is in, and number one, if we do not know their comorbidities that are contributing to the reason why this wound is not naturally progressing through the phases of healing. Okay, so you have to know those things. If you don't know those things, I'd be glad to provide you a PowerPoint or discuss it with you to educate on wound assessment. But let's talk about wound healing. So after we have thoroughly assessed the wound and we know what we're looking at and we know why the wound isn't healing, we can address and understand that we know there are 4 phases of wound healing. The majority of chronic wounds, which is why wound clinics and wound care specialists exist, the majority of chronic wounds get stuck in the 3rd phase in between the 2nd and 3rd phase of healing. So understanding that, we know that we need to focus on where they are in the healing process. And we need to figure out what sort of wound care, what sort of modalities and dressings we need to implement to help these wounds carry into the 3rd phase of healing, where they're stuck, and we need to remove the bacteria. We need to help them to make blood vessels, to promote angiogenesis, and to round up cells to heal wounds. That is the most basic terminology. I have it all laid out otherwise, but we're going to blow through this in 10 minutes. So we want to implement things that are going to help them to build a new, stronger matrix, to give that extracellular matrix something to grab a hold of and actually implement into the wound bed so that can fill with granulation, it can cover with epithelium. So chronic wounds are wounds that don't show definite signs of healing within 4 weeks. The most common 3 types of chronic wounds or causes of chronic wounds are diabetes, venous insufficiency, and pressure. Of course, under that umbrella of diabetes, you have the impaired cellular function that comes with that, the arterial insufficiency, which results in the lack of oxygenation to the wound bed and nutrients and waste removal, the decreased immune response, which therefore increases the risk for infection. Neuropathy, which delays their seeking of care of these wounds. Edema, venous insufficiency, which is edema is secondary to, which results in a capillary collapse. Again, that has the same result as arterial insufficiency to the wound. Far more different comorbidity, but the impact that it has on the healing of the wound is that there's no oxygen, no nutrients, or waste removal. Those are 3 key pieces to healing a wound. And then pressure. There's poor offloading that causes that chronic inflammation, poor tissue perfusion, again, lack of oxygenation, and therefore tissue death. So we must first know why the wound became chronic. That chronic wound environment is an environment that the entire microenvironment is off. The inflammatory signals are not correct. Often there's decreased angiogenesis, therefore no oxygen, no nutrients, poor signaling of growth factors, unhealthy or non-existent extracellular matrix. There's poor destruction of bacteria, therefore bacteria are consuming the oxygen and the nutrients that the wound is needing for healing. Therefore, there's also an increased risk of infection. All wounds have bacteria. I think we'll discuss biofilm in a second here, but the destruction of without removing that bacteria load, without managing that biofilm, it's causing additional detriment aside from just the bacteria themselves, but the damage that the bacteria provide. And then an overgrowth of MMPs, which the MMPs degrade that extracellular matrix, which is the framework for everything to hold on to. So we have to interrupt that cycle. We have to figure out how we can intervene. If it's that we need to ensure that they have adequate blood flow to the wound, arterial ultrasounds, vascular workup, smoking cessation. We have to decrease that inflammation, check their hemoglobin A1C, help them with diabetic control, refer to endocrinology, debride the wound weekly to remove that bacterial load that is on the wound bed surface and remove that non-viable tissue. That is huge. That's the biggest gift we can give these wounds. Offloading to decrease the trauma and encourage the healthy microenvironment to control those comorbidities as much as possible and to optimize nutrition. So all of the aspects that we're focusing on, really, as far as those comorbidities, mostly have the same outcome on the wound bed itself, but we have to make sure that we properly identify the comorbidity that is contributing to the non-healing chronicity of the wound. Wound management. Biofilms, I mentioned just a second ago. If you are in the wound care world at all, you are familiar with the term biofilm. So I explain biofilm to my patients as this, that bacteria live on all wounds, not just infected wounds. They create this interlocking web of bacteria that protect each other and live and eat and survive on the wound bed. We have to figure, and that delays the healing tremendously, as I mentioned before. They are taking those nutrients that wound needs. They are increasing the demand for oxygen. They are decreasing the ability of the wound to heal because the bacteria are feeding themselves. So I described to patients that our goal is to remove that, which the best way to do it, there's tons of products on the market. A lot of those are damaging to the good cells as well, like cytotoxic products and Dakins and things that have a purpose for a short amount of time, but not chronic wounds. So we've got to manage that biofilm. So debridement, and I usually do that. Debridement gets rid of it. There are some wound care products that can help turn this biofilm from living and eating in the wound to living and eating in the product so that the wound can still heal and progress at a normal rate. It only takes 24 hours for these boogers to reform. So vigorous cleaning and excisional debridement is crucial to managing biofilm. Antiseptics, I just sort of touched on that, but antiseptics have their place in the wound care world. A lot of them can be or are cytotoxic, but they still have their place. On these super chronic wounds that come in, sometimes it is necessary to use a cytotoxic antiseptic to get that biofilm under control. I mentioned Dakins earlier, but short term, let that be a takeaway, short term. Otherwise, great. There's tons of wound care cleansers on the market that are surfactant based that are not damaging to the good cells. Debridement. Yay! That is the #1 most successful research-based method of chronic wound healing. So there are 3 different types of debridement: surgical, autolytic, and enzymatic. Surgical being the most effective, also can be the most traumatic to the patient in some circumstances, but it's going to remove the biofilm and the bioburden. It promotes that cellular migration. It signals that the body has a wound. And that's how I always describe to my patient. I say, this is a way that we basically recreate a new wound for your body, not to torture you, but to restart that whole healing cascade so that the body can restart the healing process again and sending all those cells that you need to the wound bed. Autolytic debridement, of course, doesn't accomplish that, but it can help to remove that devitalized tissue with your own moisture. It's slower, but it's less aggressive. Obviously, and side note, this is from previous, but I want to throw in I so often see antibiotics inappropriately given for wounds that are being autolytically debrided, and oftentimes that is slough as drainage, not pus. Not pus. If a wound has been covered for 5 to 7 days and it's got that yellowy type drainage on top, but there's no other signs of infection, it is not pus, and they do not need an antibiotic. Okay, off my soapbox. Enzymatic debridement, there's one on the market. It's called Santyl. It's a collagenase. It must be used with moisture in the wound bed. Takeaway, don't put that over dry, hard eschar. It won't do any good. So there's loads of topical dressings on the market. I'm going to try to breeze through these as I'm coming up on time and I want to get to some more advanced things. So the goal of wound care, you want to manage moisture. Wounds need a moist healing environment, but if it's too moist, you're going to wreck the peri-wound. So you want to use products that can enhance autolytic debridement, maintain the moist environment to allow for cell migration, eliminate dead space. You want to minimize the frequency of dressing changes. Every time you change a dressing, you're disrupting those endothelial cells that are trying to hold on to something. You're changing the temperature of the wound bed, but cost efficient, etc. So I'm going to breeze through these, but you want to protect the peri wound. You want to use a non-contact layer, no dry gauze on wound beds, because A, it's torture to the patients, and B, it rips up the wound. Alginate, hydrofibers, things that manage the moisture. Hydrogels, again, manage adding some moisture to the wound bed. Foam, they can last a while and maintain the wound bed temperature. Super absorbents, wick away that moisture to protect that peri wound and decrease the frequency of dressing changes. Collagen's a synthetic matrix that allows for those cells to migrate, kind of giving them a scaffolding to hold on to. Occlusive film dressings can protect against damaging moisture. Takeaway here, antimicrobial silver is okay for a short term. It is not long term. It creates those endotoxins get released because it's killing the bacteria. It is creating an inflammatory state, and it is contributing to why wounds get stuck in the second phase of healing. Advanced wound care modalities. I know this is what I was supposed to focus on the most, and now I'm going to have to fly through it. Okay, negative pressure wound therapy, excellent option for wounds that have depth and excessive drainage. They work excellent in conjunctive therapy. It's a bit of an inconvenience for some patients, but once they see the effectiveness, they don't care because it can accelerate that granulation tissue. It can decrease that edema peri-wound, which increases the perfusion to it. It helps to maintain a moist environment. You can decrease the frequency of which the wound has to be changed. I standardly change them twice a week. Excellent option. Instill is another type of negative pressure wound therapy. Amazing outcomes. They're only in the hospital and in outpatient facility, or in, like LTACs, long-term care. I encourage you to look at them. You're adding moisture to instilling fluid and sucking it back out. Beautiful outcomes. Biologics. Let's pause. Let's slow down here for a second. 3 types. We primarily use the allografts. They are donated from placenta. So we've already recognized that there are reasons why wounds won't heal, because they can't get what they need to heal. They can't get the oxygen, the nutrients, the perfusion that they need to heal. So after you've addressed those underlying comorbidities, you've identified them, you've addressed them, still you may have a continued delay in healing. Biologics, you can put those living cells directly into the wound bed. Amazing, amazing outcome. Of course, there are all sorts of regulations and checkboxes you have to go through to be able to use them. They go in on a weekly basis. There is no trauma to the patient, but you put those cells directly into the wound bed rather than relying on the body who has already failed because of comorbidities to get them there. So they can rebalance that entire microenvironment. You want to put that graft in, protect it for a week, and reassess a week later. Hyperbaric oxygen therapy is the mega of all treatment, and it can be a great adjunct to any other treatments that we have discussed. It's performed in the outpatient wound center at Park Ridge. We have 2. We're ready for 3. Come on, bring us some patients. Diving patients. They go into this chamber you can see here in this photograph. It's open air. These are our actual chambers. They have TVs above them, but they go in and there's an atmospheric pressure that's placed just as though when you dive underwater. Same concept, which is why you hear the term diving them. But it's under pressure, 100% oxygen. So it increases that concentration gradient for oxygen to improve the ability for it to diffuse to the wound, promotes angiogenesis. Patients must dive 4 times a week for it to be a therapeutic treatment. Depending on the diagnosis, they could be up there for a couple hours. So it's quite a commitment for patients, which they must know. And then, they might be doing it for a month or 2, depending upon their wound status, their insurance, etc. Most qualifying etiologies for HBO are diabetic lower extremity wounds. Big time. They must be a grade 3 or higher, but there are so many diabetics in this area that are missing out on hyperbarics. Wow, that is a tremendous benefit to those patients, especially think about the pressurized system plus the oxygen to those far distal areas. Osteoradionecrosis, chronic refractory osteomyelitis, failing flaps or grafts. They must be, and this is where I want you all to know who qualifies, but then know what qualifies them, because those patients must be in the chamber within 14 days of surgery. That is some fast communication, some forethought, some knowing where you're headed, because that includes insurance authorization. Radiation soft tissue injury, they must have completed radiation 6 months prior, but wow, these patients who have exposed bone in their scalps or elsewhere, wounds that they just won't heal because they're surrounded by such damaged scar tissue. Radiation cystitis, hello, urology, I know those patients are out there. Acute arterial insufficiency, again, those patients are out there, but knowing what your options are so that you can be acting in advance, because they must be in the chamber within 72 hours of that original event. Okay. Blew through that. So much more I would love to share and talk about. Please reach out to me. Lovely to be here. Enjoy all of you today. Thanks again.